Hello everyone, and thank you for joining me this afternoon for my case study presentation. I will be presenting a patient with cystic fibrosis exacerbation with the comorbidity head and neck cancer. So my objectives today are to go over the patient background, a cystic fibrosis overview, a brief overview of nasopharyngeal carcinoma, history of present illness for the patient and pathogenesis of her disease, labs and medications, medical course and treatment, her entire nutrition course, and a summary and conclusion with references and a question and answer. So HM was my patient. She is a 30-year-old Caucasian female. Her social history includes working as a chiropractor. She lived in an apartment with her mother, who is an APRN and helps with her care. She did not have any identified food insecurity, so she was able to get all of the care that she needed, nutrition-wise. Her past medical history includes CF. She had the F508del homozygous genetic background with preserved lung function. She did have some pancreatic insufficiency and cystic fibrosis related diabetes. She did not have any surgical history on file, and her new diagnosis on top of her CF is stage 4 poorly differentiated nasopharyngeal carcinoma. And her chief complaint while in the hospital was CF and recent cancer diagnosis. So a little bit about cystic fibrosis. So it's an autosomal recessive disease, which means that you need two copies from two parents. It's a genetic disease affecting more than 70,000 people worldwide right now. It's progressive, so it starts out in the beginning a little bit less detrimental than it would be later on. It progressively gets worse. So organ function declines over time. So a little bit of the genetics. So the mutations in the cystic fibrosis transmembrane conducting regulator gene, that's a specific gene that's affected. And this gene creates a chloride channel on the cell surface. So there are multiple, 1,700 plus different mutations that they've identified that may cause this. And these genes cause variations in symptoms and severity of disease from each individual. And life expectancy for this disease has dramatically grown in the past few decades. I remember briefly in middle school when we were learning about CF and I had heard about it for the first time. The life expectancy was maybe your late 20s, early 30s, and now it's grown far beyond that, a few more decades beyond that. And there are patients that are living into their 60s, so it's a good breakthrough. So this is a chart I made about CF just to outline what I just kind of spoke about and go into a little bit more detail. So a mutation in the CTFR gene, which we discussed, genes create proteins. So this mutation causes a dysfunctional protein, not a normal one that a normal person would have. And this dysfunctional protein specifically acts on the ability to move chloride ions to the surface of the cell. This affects water balance on the outside of the cell, so on the cell surface. So if the water is not balanced because the fluoride ions are not moving through the sodium channel to the surface of the cell, it creates a thick, sticky mucus that covers, multiple different organs, as we see here, like the lungs. It clogs airways in the lungs and traps pathogens. So the mucus creates an environment for the pathogens to live in there. Which causes multiple infections, and unfortunately a lot of these patients are hospitalized often for IV antibiotics. It affects the pancreas, because the mucus pretty much clogs the pancreatic ducts, inhibiting release of hormones and enzymes needed for digestion. And it affects the liver. The mucus blocks the bile duct, further affecting digestion for these patients. Pretty much the entire GI tract is affected. Most affected is the small intestine because that's where most of the digestion occurs. Some patients are also unable to buffer gastric acidity. Some of them are unable to regulate that. So they're put on some proton pump inhibitors in order to stabilize that a little bit. It's a common medication. It also causes overall malabsorption of macronutrients, but again, mostly in the small intestine because most of the digestion occurs there. And poor absorption of fat-soluble vitamins. So if you're not absorbing the fat well, you're probably not absorbing the vitamins either. And in men, this disease affects their reproductive system because it blocks the vas deferens. So most of the men are infertile and go for alternative methods of contraception. So I wanted to go over nasopharyngeal carcinoma briefly. This is a presentation about CF, but my patient did have nasopharyngeal carcinoma diagnosed, and I wanted to just give some background. So as you can see here from the diagram, this is the nasopharynx. Where it's located, it's near where the trachea is for swallowing. And we can assume that if there's a mass there, like my patient had, it would be difficult to, eat. You'd have swelling and so forth, but I'll go over that a little bit more during her symptoms. So nasopharyngeal carcinoma, it's a cancer. Cancer is malignant cells. It's just a cancer that forms in the nasopharynx. Stage 4 are generally metastatic cancer, meaning that they have moved on from their original source and usually have, complexities like their own blood vessels supplying their nutrients and so forth. Treatment is usually generally chemoradiation and then a course of chemotherapy by itself, which you'll see my patient did have a little bit of in a different order. Cancer and treatment generally increase calorie and protein needs in anybody, not just anyone with CF, but as we know, with any patient. And head and neck cancers generally affect the patient's ability to meet elevated needs since they're having trouble eating and taking in that nutrition. So a history of present illness for my patient. So this is her CF history. I'm also going to go over her cancer history following. So for CF, children are usually diagnosed young. My patient was diagnosed at 6 months of age. Her mother would kiss her forehead and notice that her skin was very salty. She was diagnosed with failure to thrive previously. She was, not very big. So they diagnosed her with CF when she was young. This was not us. This was in the Midwest from home. Originally, she was from the Midwest with established CF care, but HM moved to Connecticut for a new job and established care at Yale in 2018. So when she came to us, she had a good appetite, good intake, and good blood and glucose control. She was maintaining weight with a BMI of 25.4, which is above the goal for CF of 22 for females. She had stable stool patterns on pancreatic enzyme replacement therapy. So she was taking enzymes. And she had preserved lung function at baseline. So she had good lung function. So when I saw her on January 6th, she came into a routine CF clinic visit. And we noted that she did have weight loss of 2.5 kilos in 3 months. She reported that she was diagnosed with TMJ, which is a form of lockjaw. She was having trouble chewing. Her face was very swollen. I could see it from visually, the swelling in her face and neck. So she wasn't eating very well. I'll get into the treatment of that. And then in April, she was admitted to the hospital for pulmonary exacerbation, and was treated with antibiotics for that. That's a common hospitalization for CF patients. So her course for cancer was a little bit more involved. So she was admitted January 21st, a little bit after I saw her due to worsening jaw and neck pain and swelling. She was found to have a necrotic lymph node. So her mother flew in to help with her care. She had further weight loss of 6 kilos on top of her 2.5 that she already lost. They took a needle biopsy of her lymph node, and it showed malignant pathology. So they did find cancerous cells there. And she had a MRI on the 31st, which showed a right nasopharyngeal mass of 3.8 centimeters. So that's pretty big if you visualize that. It's not huge, but it's definitely big enough to cause these symptoms. And that extended to the right oropharynx too. So it was quite large and did inhibit her ability to swallow and chew. So they diagnosed her with right nasopharyngeal carcinoma at that point. So she did leave the hospital and came in for outpatient chemotherapy induction on 2/17 to 3/9. And then they did a MRI of her face again on the 23rd of February, and it showed an increase in size of the mass. Her ongoing weight loss caused the intervention of a peg being placed to ensure proper nutrition, since she wasn't able to really take it by mouth. And then definitive chemoradiation started, so her last course started on the 30th of February. And then in April, she finished that course, but was admitted for difficulty breathing, bilateral lung opacities, and hyponatremia. And her weight was decreasing even further. So I just wanted to go over the spread of her cancer very briefly. So the primary tumor began in the nasopharynx. The necrotic lymph nodes were involved due to metastasis. It extended into the right oropharynx and the masticator space and the right carotid space. So now it was gaining space near her blood vessels. It extended prevertebrally to the foramen, and extension to the cervical spine 1, and involvement of the vertebral artery and right internal carotid artery, and compression of her right internal jugular vein. So it was growing. She had, as we know, severe right-sided neck swelling, pain, weight loss, difficulty chewing and swallowing due to this. So these are her labs over the course of her admission. Outpatient. These are outpatient labs. They're outpatient labs. So I'll check on that. So as we can see from these labs, she has chronic hyponatremia. But this, again, is a symptom of CF, as we discussed, the biochemistry of that. It could also be just general salt loss or syndrome of inappropriate antidiuretic hormone, which she was diagnosed with. Chloride is also related to sodium and CF, obviously. So it makes sense that those would coincide together and also be low. So her creatinine is chronically low as well, due to poor PO intake, or possible causes, or low muscle mass in general. Her hyperglycemia is due to her cystic fibrosis related diabetes, and also the metabolic stress that she's probably going through would elevate her blood glucose a little bit more as well. And her liver function is notably impaired. This could be due to CF also. And these are some of the significant medications that she was on. So throughout her course, she was on multiple medications. I chose the most pertinent ones through outpatient and inpatient that I thought I would like to discuss. So she was on Relizorb, which I'll go into a little bit later. So the indication for that was pancreatic insufficiency and G-tube feeds. It hydrolyzes dietary fats and protein for her. She was on vitamins and salt tabs because of her malabsorption, just to ensure that she's getting what she needs. She was also on a specific CF multivitamin, BID. So again, because of lack of fat absorption, lack of fat-soluble vitamin absorption also, which means that those need to be supplemented in an absorbable form. She was on an inhaler for bronchospasms. She was on Kate Farms 1.5 peptide. So that is a peptide-based formula that's concentrated, high calorie, high protein, and easily absorbable. It's a common formula for CF patients. A lot of patients like it because they perceive it as a little bit more natural. It's free of a lot of common allergens. And she was also on Zenpep-Pio, those are CF enzymes. A notable side effect for those is fibrosing colon. So we don't want to overdose on those. So her cisplatin I included on there. Overall, all of the chemotherapies and cancer treatments have similar symptoms, but I included this one especially as a medication. So she did experience dry mouth, vomiting, often with no nausea, but some nausea. Definitely fatigue and mucositis from that. And her compazine, which is an antiemetic, also causes dry mouth, which she also did have. So I wanted to briefly mention Relizorb. So it's a cartridge for digestive enzymes for patients with CF that are on tube feeds. It's for tube feeds only. So the cartridge actually attaches to the tube itself, and the feeding runs through it and is digested before the patient ingests the formula, which is pretty cool. So it's designed to break down macronutrients before ingestion. In studies, it's been shown to normalize plasma concentrations to levels consistent with the reference range. And it's this is in children ages 5+ and adults. So it's not indicated in patients younger than 5. It's for use with a pump system only. And it's dependent on formula compatibility. So a lot of the formulas that have a bunch of added fiber or formulas that are not as broken down are not as compatible. For example, Gevity, any Gevities would not be compatible, whereas the Kate Farms peptide is and osmolite is. If anyone's interested, I can provide a list of all of them, but generally the more broken down formulas are the ones that are compatible. And without added fiber. So, treatments. So we have, at the top, we have a summary of radiation therapy that I wanted to include just for you guys to take a look at. So she had that for just under 2 months, as we saw in the history. Her CF treatments were pretty straightforward. They were basically airway clearance. She didn't have many treatments because her lung function was preserved at baseline. So she would do percussion therapy, which is when you hit your chest with your cup palm, and it kind of loosens the mucus in there. This is really a therapy. and it helps. And they also have a vest that will do that for you. It uses high frequencies to loosen everything up in there. And then the patient will use that for a few minutes and then take a break and cough and get rid of some of that mucus, just to help clear their airway. She was also on the nebulizer, which we mentioned. Tube feeding, so she was on tube feeding. Not all CF patients need to be on tube feeding, but she did need it. It was indicated for her. And she was also on enzyme replacement therapy. And for her oncology, this is her induction regimen. I'm not going to go too deep into the chemotherapy, but this is, a standard TPF induction therapy. She had 2 cycles. There aren't any more of those planned. She did move on to a definitive chemoradiation with weekly cisplatin. Her first dose of the induction TPF was decreased because of her elevated LFTs, which we saw in her labs. And her current treatment is surveillance. So they're watching her tumor. All right, so let's get into nutrition. So after all of that, her background. So her diet history, before all of this trouble, she was on a high-calorie, high-protein diet, like most CF patients are, 3 meals, 2 to 3 snacks per day. Then she kind of progressed to soft foods and liquids when she was having trouble with her TMJ diagnosis. And then she moved on to calorie-dense liquids after that. And then she got her tube placed. So she was tube feed and liquids by mouth because she could still tolerate those. And eventually she was NPO with nutrition via PEG because she just couldn't tolerate anything anymore. Her nutrition prescription inpatient was based on a dosing weight of 44.5, which was adjusted for BMI less than 16, CF, cancer, and repletion calories. So it was 1,600 to 2,100, and her protein was 80 to 106. Her hospital diet order was tube feed with tray, high calorie, high protein. They wanted her to order as much as she wanted. She was getting Kate Farms at 100 milliliters an hour times 13 hours. So that was giving her 2,000 calories and 96 grams of protein. So that was meeting her needs within her range. They also wanted her to eat by mouth. Again, these patients can have as many calories as they need to. So this is her diet or her weight history. So as we know, Epic is not 100% accurate with all of their weights and their scales, but regardless of the fluctuations, this chart clearly illustrates weight loss and, decline in weight. So we confirmed her height. Her current weight was 37 kilos. That's 81.8 pounds. So that's pretty small. Her BMI was 14.4. Ideal body weight was 44.5, again adjusted for BMI less than 16. Her usual body weight was 62 kilos, which she last weighed in December. As we can see by the chart, it doesn't go back as far as December, but in April she was around 47 kilos. I don't know if you can see that. It's kind of small. I apologize. So overall, she had 21% weight loss in 6 months. So that is significant weight loss. So her diagnosis was malnutrition related to disease symptoms as evidenced by weight loss and poor keto intake. And that continued at follow-up with further weight loss and inadequate enteral nutrition. So she wasn't getting all of her tube feeds because of intolerance and also just because sometimes patients don't get all of their tube feeds because of their treatments and procedures and all. And especially since this patient bounced from outpatient to inpatient, she wasn't always getting all of her tube feeds at home. So we have a lot of rationale for this diagnosis. Not all of it is included in this one PES statement, but I did want to go over it. So her weight loss, significant time frame, dietary intake. So she was obviously consuming less than 75% for 3 months. Nausea and vomiting for her GI, comorbidity, cancer, her extremely high metabolic energy, metabolic demand, her energy requirements, and her need for repletion. Her body just couldn't keep up with it. Swallowing difficulty, wasting, so she did have some mild temporal wasting identified. So Dietary management and MT principles of CF. So CF patients have increased calorie and protein requirements. They have an increased work of breathing because they always have this sticky mucus, so it's hard to breathe. They have malabsorption and increased nutrient losses, meaning they need to take in more to get something. Proper nutrition can promote overall health and pulmonary function in these patients. So if they're getting enough, their body can keep up. So high fat, high calorie diet can facilitate weight gain and help patients reach BMI goals. Often eating calorie dense meals and snacks, as many as possible pretty much, to keep up that weight. Supplementation is common because it's easier. But including fruits and vegetables due to the inflammatory nature of the disease. So it's still, eating peanut butter and butter and olive oil in your soup and all of that stuff is really important, but also having a balanced diet, just to support overall health is important. So supplemental enteral feeding is used when appetite is just not enough, which is it's more common than we think. Not in all patients, but it's common in CF patients to need a little bit extra, whereas it's enteral feeding or nutrition supplements, PO. So eating fatigue is common. I mean, some patients need 3,000 to 4,000 calories per day, and I eat a lot, but I don't know if I could eat 4,000 calories per day every day, just to keep up my weight. So it depends on their weight and their lung function, but they get eating fatigue and they just need a little bit of help. So our intervention for HM so we had a few. We had food and nutrient delivery. We gave her supplements at the beginning, so Scandi shakes, protein powders, and then we moved on to enteral nutrition when she needed it and when it was indicated. So we gave her, she was doing bolus 4 containers a day, and those are her needs from when she was getting continuous also. They just switched her to bolus while she was at home. So we provided various nutrition education topics like salt tabs, enzymes, weight and BMI goals in CF, blood glucose control because she had the CFRD, structured meal and snack times for her to meet her high calorie needs and keep her blood sugar stable, vitamins that she needed, adequate hydration, which is a big one in CF because of the mucus. You want to keep it thin. Salty foods to increase sodium, and high-calorie shakes for swallowing difficulty. We provided some ideas for her for that. We provided problem solving to various, chewing difficulties and stuff like that with her. We coordinated care, so this was a big one because she was going from outpatient to inpatient, oncology and CF. So I know my preceptors coordinated this presentation because she was just complicated and she needed a bunch of different services. And factors that affected her compliance were she did have a lack of motivation towards the end of her course and depression, just given everything that she's gone through. I mean, anybody would really have, I wouldn't say anybody, but I see why it was difficult to keep up with everything. So we monitored all the different topics from our NCP. So her goals inpatient were to consume 75% meals prior to next nutrition assessment. Patient to continue home tube feed regimen after discharge of Cape Farms peptide. So we monitored food and nutrition intake, administration, medication, food and supply availability, nutrition quality of life. We monitored her height and weight and her BMI, her biochemical data, tests and procedure outcomes. So her tests, all of her scans and her lab data, and her nutrition-focused physical findings. So we did know her physical appearance, her wasting, swallow function, and her appetite. So, to summarize, CF is a genetic disease that affects tens of thousands of people worldwide. So it may not be as common as some other ones, but it's certainly notable. Nutrition care and counseling as part of the multidisciplinary team in CF is critical to patient quality of life. So we can see how, nutrition plays a huge role for these patients, with their symptoms and their overall, energy to keep everything up that they need to keep up, and to combat, those high metabolic needs. New treatments are increasing quality of life and life expectancy, which is, we like to see. A new drug that I wanted to talk about briefly was Trikafta. It just came out a little while ago. I do not think, as far as I know, my patient was on this, but it actually does affect the chloride channels on the surface of the cell. So that is approved for children ages 12 and up. So if you have a CF patient and you'd like to discuss that with the doctor, maybe it would help a little bit with their symptoms. It's promising. So some challenges ahead for HM. So she was placed on COVID-19 rule-out precautions on her chart. There was no positive test or anything. They did want her to come in and check because it is a respiratory disease. The patient declined coming in for testing at the moment because it just, she's on home hospice, so she doesn't want to just, make a big deal out of that. She didn't see that it was worth her while to get tested because of her status. So she's on home hospice now, but she is maintaining her quality of life as best she can. These are my references. If you want any further references, I do have details about Realizorb or Trikafta or anything you're interested in. If you just email me, I can send them, courtesy of Dana also. Any questions or comments for me?